And here on the main stage, I will call for the healthcare system service in Catalan. So we will have Oriol back here with a group of people who will share their experience. Oriol, you left the harbor. It's
Yeah,
okay. You're in one of our cabins.
yeah. So as we arrived to the dock, so I can arrive to the land and make this presentation. So thank you, Chris, and thank you, crew, for
Okay.
all this work. And now we're going to start with the first ship, okay? And the first ship is a really big ship. Is the Ministry of Health in Catalonia. They're going to tell you about, but it's it's a public healthcare. They are serving more than 7 million people, and they have just a minor challenge: how to change the primary care in healthcare. All, all of them. Okay, this is amazing, Chris. This is amazing. So now you're going to
Okay,
meet them.
perfect, Oriol. I will leave you with the session.
Okay,
Bye.
thank you. So now I would like to invite Clara, Geroni, and Danielle. They are truly three lean practitioners from the Catalan. Hello, friends, for being
Hello.
here. They're going to explain you, but we have been talking about these big ships, small ships. This is a very big ship that it's not only a ship, it's a flotilla of ships. And you have this very small challenge that is to change healthcare from the bottom. And now we're very curious because, okay, you're healthcare, but at the end, you're a very big organization with thousands of workers. I think that just in primary care, it's more than 20,000 people or something like that. So more than 400 sites, 400 ships. You're going to also to tell about that. So when a company wants to make a change like the one that you have been doing, how such a big company can do that without losing the essence, without lost in translation? How this is possible? If you can make some light on this.
Yeah, do you hear us?
Yeah, we hear you.
Yeah, sure, Oriol. Thank you. Thank you very much for this introduction, and thank you to the organization for letting us to share our experience here in this event. So when we started 2 years ago, the assignment given to us was to transform, as you said, an entire primary healthcare system in 2 years and after a pandemic. So that was a difficult situation. So we knew that it wouldn't be an easy fit, but we knew that we had to be we had to do something different to what had been done before in the system. But let's just start from the beginning. We are coming from Catalonia, that is a region of Spain in Europe. You may know Barcelona, you may know Sagrada Familia. Also, Leo Messi could sound familiar to you. But today, we want to talk about the Catalan Health Service, which, as Oriol said, is a large and traditional organization who provides public healthcare to 7.7 million people. And this is for free for the population. And we want to talk about primary care. So for you to understand what's primary care, so primary healthcare is the first point of access in the healthcare in Catalonia. And from there, you can access the rest of the public system services, like hospitals, for example. But okay, let's try to understand better how is it going, no? We have for a given population that it can be a town or it can be a neighborhood. There is a group of professionals, of healthcare professionals, that can be medical doctors like general practitioners, nurses, assistant staff, even pediatrics or social care. They are organized as a primary care unit, that is a very important concept, and then they are providing the population some medical attention when they need it. They can provide health checking, medical advice, diagnosis, medication, etc. So this primary care unit is the essence of our project. So it's very important for you to understand what it is, because to give this attention to 7.7 million people in Catalonia, there are 373 primary care units across all the country. And they are managed by 38 primary care provider organizations. So notice the complexity that the system has, because they have to provide the same attention, even if it's in a busy neighborhood in Barcelona or in a rural area in the Pyrenees. So this situation is very, very complex to manage. And primary healthcare in Catalonia had been historically in a constant strain. But this situation was made worse during the pandemic, where primary healthcare had to do a lot of extra tasks, like, for example, vaccination to these 7.7 million people. So as you can imagine, the situation is difficult. It's difficult to manage, and we can say that we were in a rough sea with 373 primary care units that we can see as ships. Notice that each one of them is different from another. Each one of them have their own crew and their own captain, but we need to sail them with in the same direction, because we have clear that we want a primary healthcare more accessible, resolutive, equitable, proactive, and efficient. So we know that this is a hard work, and the journey would not be easy. But we have to give the tools to these crews to manage to arrive to the same place and to go to the same direction. So we were wondering three big questions that were: how do we change the way of working to sail all of them in the same directions? How we can give them tools? How do we find solutions to problems that are common in these 373 organizations, but also considering their specific needs? How do we can standardize the care that Catalan citizens are receiving? So these are big questions, but as we are strong lean believers, let's say, we knew that a lean strategy could help us to solve all these questions and guide us to where we want to go. So now I will introduce you, Clara, that will explain the methodology and the deployment that we've been doing to do such transformation. So Clara, please.
Thank you, Jeroni. And hi, everyone from my side. I will explain to you the methodology we use, the lean management, in order to do all this deployment. So it starts, this deployment, with the strategic commitment of the organization management. We know that without that, it couldn't have been possible. So our first step was to create a team of process engineers and clinical experts, and with the strategic support of Essentia Health Management and the Lean Management Institute. After that, our second step was to include lean training in order to give to the ship crew, the professionals, the knowledge and the tools in order to know how to teach them in order to how to use the tools, the sales, sorry. So now it was the point in which we have to figure out how to work with each unit. So we created a plan of 10 sessions in following the PDCA structure: plan, do, check, and act. So the first 4 sessions are in the plan phase, and it starts with a kickoff session where we include personal interviews, then 2 sessions of lean training, combining theory and cases study, and finally an analysis session, which is really important because it's where we draw the value stream map and where we understand their situation and detect their real needs. So after that is where it starts the do phase with the improvement opportunities session. This is really important because we cannot work with all the projects, so it's really important to prioritize between according to effort and impact, and combining their perceptions to the real KPIs between all their needs. So the final objective is to develop projects and create impact to the whole system. So by implementing quick wins and mid-long-term projects. So these quick wins will allow professionals to rapidly understand the methodology, and the mid-long-term projects will be the ones that will be significant and strategic for the health system as a whole. So that's why the next 4 sessions are working groups in which they work with these 2 types of projects. And finally, and the really important session is the project monitoring system session, where we define the KPIs and we fix a day in which they will start implementing the project. So now we were in a point in which we knew how to work with each group, but we need to think on the strategy deployment. What did we have? We had 2 years, and we knew that we should avoid waste. So that's why we were organized in cycles of 60 units, primary care units each. And in the beginning, we carefully focused on some specifically units, gathering as much information as we could in order to understand the situation, to understand where were we and what we wanted to achieve. So we reached the point, more or less, in the third cycle in which we were able to standardize solutions and be more efficient in the project implementation. For us, it was crucial not to reinvent the wheel. So we have involved every time more and more professionals. We have reached a 10% of professionals in primary care who are trained and are involved in developing projects. So what does it mean, this? No? This means that there are more than 1,800 professionals trained, which all of them are working on developing projects. So lots and lots and lots of projects are being implemented, and teams are really motivated because it's the first time that the Catalan Health Service is working directly with the crew, the professionals from the base.
Wait, Clara, wait. So I understand the process. So I imagine in all organizations to have the commitment of the management is very important, but you are in a political, so more difficult that you have been doing is impossible. So I think that you are a very good example. And I understand the deployment. I see here a lot of examples, but Clara, can we see one of these examples to understand how big is these small examples?
Yes, of course. We can go to the Gemba. No, we can just go to a primary care unit from Girona in Sant Feliu de Guíxols, and they will explain their experience.
El proyecto tiene lugar en el CAP de Sant Feliu de Guíxols. Es un centro de atención primaria donde se hacen analíticas de lunes a viernes y tenemos programados cada día unos 70-75 pacientes. Hay una TCAE en el servicio y hay 6 enfermeras en el servicio. Es que los pacientes, desde que llegaban al centro hasta que se iban con la extracción hecha, podían pasar unos 25 o 30 minutos. Los pacientes, la gran mayoría, llegan a primera hora. A las 8 de la mañana los tenemos todos ahí, en la puerta. Incluso algunos antes de las 8 ya hacen cola en la calle, antes de que abra el centro, para ser de los primeros a entrar. Otra cosa era que como el centro de atención primaria tiene 2 entradas y hay 2 accesos, los pacientes podían entrar y llegar al servicio por diferentes escaleras, por diferentes puertas, y aquí sí que hicimos un espagueti y vimos pues eso, cómo de enredado era a veces el circuito de los pacientes. Otra cosa que pudimos observar es que cuando entran a la vez 20, 25, 30 pacientes, pues había una sensación de caos y de confusión en ellos porque no saben, la TCAE no puede atenderlos a todos a la vez, entonces mientras esperan no saben dónde sentarse, dónde situarse, qué hacer, si les van a recoger la muestra, si no, y la sensación era un poco de caos. Y desde dentro me refiero, las enfermeras desde las consultas también, pues se oía jaleo fuera en la sala de espera y es la sensación de desconfort, ¿no? Los 70 pacientes pasaban por la TCAE, todos, y era la TCAE la que los distribuía a las consultas para que las enfermeras pues, sacaran la sangre, ¿no? Entonces, claro, aquí vimos un embudo realmente porque todos pasaban por ella y eso enlentecía a las enfermeras, a las cuales la carga de trabajo en algunos momentos era inferior a la que podían asumir, al contrario que la TCAE, que tenía una carga superior de la que podía asumir porque no les podía atender a todos. Otra cosa que hicimos es cronometrar el tiempo que estaba la enfermera con cada paciente y cronometrar el tiempo que también estaba la TKE con el paciente. Bueno, estaba muy claro, los pacientes como estaban programados a cada minuto y le llegaban a cada minuto, pues a la TKE le faltaba tiempo, un minuto no era suficiente para atenderle, recoger la muestra, darle las etiquetas y orientarlo hacia donde tenía que ir. Y lo mismo con enfermería, pues que le sobraba tiempo porque hasta que le llegaba al paciente con la muestra recogido y con la petición y con las etiquetas, pues le sobraba tiempo, ¿no? Hicimos como un mapa de situación con en todos los puntos en los que detectábamos problemas o donde nos encallábamos, por así decirlo, ¿no? Y fue cuando vimos que teníamos que balancear las cargas de trabajo porque tal y como lo teníamos, pues era evidente que no nos podía salir mejor, ni que pusiéramos más enfermeras, no era la solución, ¿no?
Dentro del tema de que los usuarios estaban como perdidos, no sabían por dónde ir, pues redistribuimos el personal y los espacios, y lo que hicimos fue separar la sala de espera en 4 partes que coincidía con el tema de la programación de los pacientes en bloques de 15, que era el primero que entraba, el primero que salía, el first in, first out, dentro de cada bloque. Entonces, también, como ha comentado que había 2 entradas en el centro, pues pusimos carteles en cada una de las entradas diciendo que todas las extracciones, las analíticas del servicio de laboratorio se entraban por una única puerta. Y también, como tenemos escaleras para ir hacia el servicio, pues hemos puesto unas cintas con el cartel de que no se puede pasar, así todo el mundo tiene que entrar por el mismo sitio. Luego hay el balanceo de cargas de tanto la TKE como las enfermeras, es que la TKE no está atendiendo a todo el mundo como antes, que recogía la petición, ponía etiquetas, recogía muestras, sino que ahora lo que se encarga es de mirar la petición que traen los pacientes y colocarlos en la sala según la hora que tienen programada en el papel. Luego los coloca en la sala y luego son las enfermeras las que salen por salas a llamar al paciente, y ellas son las encargadas de recoger todo, de poner la etiqueta, de recoger las muestras y de hacer la extracción. Con esto ganamos que el paciente está menos tiempo en el centro y nos encargamos también de la privacidad, que antes se tenía que llamar fuera y ahora al hacerlo dentro pues está como solucionada la privacidad, que también era uno de los problemas. De cara a los resultados que nos hemos encontrado desde el primer momento en que lo hicimos, hemos ido viendo que hemos ido mejorando. Por ejemplo, la cola de gente, que había como unas 70 personas esperando a las 8 de la mañana, pues ahora nos hemos visto que solo vienen los que tienen de 8 a 8 y cuarto y alguno otro, pero que lo hacemos esperar en la sala como le toca, que nos referimos a unos 25 pacientes ahora mismo. El tiempo de estada, que era como una media hora, pues ahora son 10-15 minutos. El servicio antes terminaba tarde para volver a hacer las tascas de enfermería del siguiente bloque de la mañana, y ahora nos encontramos que terminamos antes del servicio, y esto es una gran mejoría. Y luego la presión asistencial de la TKE, antes era todos para ella, a más de un minuto, que no tenía ella el espacio ni el tiempo, y ahora está en un 4/10, porque solo se encargan de distribuir y coger alguna duda, atender alguna duda o incidencia que pueda haber. E incluso nos hemos percatado de que podemos asumir el servicio de laboratorio de extracciones con una enfermera menos. O sea, antes eran 6 enfermeras, ahora hay 5 enfermeras. También nos hemos dado cuenta que el tramo de analíticas urgentes, que la teníamos puesta a las 8 de la mañana con el bloque de 8 a 8 y cuarto, pues ahí podíamos programar mucha más gente por el tema de las urgencias. Luego nos estamos proponiendo de modificar ponerlos en otro tramo porque vemos que acabamos antes del servicio y la sala está vacía antes de tiempo.
Y otra de las cosas que hemos notado mucho mejor a todos es el clima, el ambiente, el ruido, ¿no? Desde dentro de las consultas donde sacamos sangre se oía siempre mucho jaleo fuera de la sala de espera y ahora realmente a veces dices, ¿habrá alguien? Porque es que no, bueno, hay calma, ¿no? Fuera. El método, que no es, o sea, no estamos acostumbrados nosotros a trabajar con esta metodología, pues ha sido de gran ayuda, y ha sido fundamental. Los problemas los ves cada día, pero no sabes cómo echarles mano, cómo empezar a tratarlos, ¿no? Y el método te aporta luz a poder decidir por dónde hay que empezar y qué es lo que realmente hay que hacer, ¿no? Y realmente pues ha funcionado, ¿no? Pues como nos ha funcionado bien aquí en Sant Feliu, pues ahora también lo vamos a poner en práctica en el otro centro grande, que es el camp de Playa de Aro.
So talking about good samples, we haven't seen live. This is the Gemba. This is excellent. I understand that you have in every single place in these 400 ships, these 400 places, bigger and smaller, you have been conducting these projects. So different streams, because in every single site, you have different streams. So different crews have been working in different streams, right?
Exactly.
Okay.
We have a lot of examples.
Okay.
We have a lot of projects, and well, I would like to thank you to Raquel, Ana, and also Lalis and all the team that is not here today for showing us this example. But I think that is the time that we can show now, Dani, some results.
Thank you, Clara, of course. Hi, everyone. This is a fantastic example of what the teams are working with, but this is only one project. As we has previously said, we are about to reach the 373 primary care units, more than 1,800 professionals trained and involved in developing projects, and with all of this crew, we currently have 40 types of standardized projects and more than 400 ongoing projects like the one Raquel and Ana have explained. From the beginning, we knew that hoshin kanri method would help us on the strategic deployment in order to ensure that everyone was sailing in the same direction. We didn't only need a project management deployment, but also a methodology that guides us on reaching our goals. As we explained before, we want to give population a primary care with these characteristics, so that is why we followed these steps. We first classified our projects into three big areas of impact. Accessibility, that means the entrance in primary care, the resolution, how to manage the attention, and the continuity of care, the interrelation between levels, for example, between primary care and hospitals. The second part was identify the key indicators to guarantee quality care. For example, the time to get an appointment to assign a doctor or nurse, the quality of care, or the waiting list to the hospital specialties. And from that point, we defined the goals of the year. Finally, when we defined the goal, we knew where we wanted to arrive and which was the actual situation. So we had a gap to share with the teams. This is a challenge that we gave to them, and they should work in developing projects and find their solutions. Now, this hoshin is used to the top level management to follow the impact of these projects. We are now managing to extend this methodology to other levels of management around Catalonia. before to finish this presentation, we would like to share some main points that we have learned during this journey. Jeroni, please.
Thank you, Danny. So yes, we want to share with you some lessons learned and some recommendations for anyone who want to try this journey to this transformation through lean methodology. So we want to share some of the lessons that we learned. At the first point is that top level management should be supporting the whole time this kind of transformation, but always with a clear vision for where we want to go, what's the target situation. Second, we have to create an experienced team in this field, but also in the methodology. So the expertise must be both. And of course, involving professionals to developing solutions bottom up, always bottom up, to achieve good results for the organization. And then the last one, and very, very important one, crucial, it's the balance between achieving organizational impact and giving at the same time professionals the tools and the methodology to solve their daily problems. So we knew this is a long journey, and in this kind of transformation, we learned that we have always to be in haste, to never stop, but never in a hurry, because otherwise it wouldn't work. So thank you very much. Our experience finished here. If you have any questions, it's up to you.
I think that is very important. So you are not going to have 400 projects. So it's not a top down. It will not work in this way. So you have to lead, you have to put the objective, to put the gap, and then ask the people how they can contribute to this gap. So this is very smart. So giving the problem, not the solution. You never are going to be so smart to provide more than 400 solutions. So this has been very, very smart from you. And this is why hoshin, that Nestor, Catalan helped to do. And here we have the real people. We have here Ana, Raquel, and we have with Lalis from the Lean Institute that also was one of the guiding people. Ana, Raquel, congratulations. So we have been seeing your explanations. And well, there is some questions from the people that has been doing on the chat. I'm going to give some of them to you. The first one is how your mind changed and how you see the problems now different from how you see it before of this lean transformation. Maybe Ana, if you can explain a little, or Lalis, help them.
Bueno, la verdad es que ahora nos hemos planteado solucionar otros problemas que vemos con la misma metodología, o sea que nos ha sido muy útil.
Yes, actually, I think that one of the things that we talk with the team is that not only the results are being sustainable, so that they are thinking about implementing them into other healthcare ambulatories, so in another areas. So I think that this is one of the most impressive things, because as everyone knows, the sustainability sometimes is the hardest part. So I think that they are doing a great job. I also want to congratulate them.
Okay, we have another question. Com afronteu ara els problemes? How do you now see the problems? I què pensàveu quan us van dir al principi? Sou vosaltres les protagonistes. And what do you think at the very beginning when they ask you, you're going to be the main characters of this transformation?
Bueno, al principio, claro, no sabíamos ni cómo ponernos. Gracias a la metodología de Lean hemos aprendido un montón, y ahora día a día que nos vamos encontrando cositas, pues ya lo vemos de otra manera. Y bueno, pues ayudándonos.
Lalis?
Yes, I also think that one of the most important things that we should do as a lean coach is trying to translate all the lean tools and all the vocabulary related with lean, like takt time, cycle time, value stream map, all those things that can be quite weird sometimes if you are not used with the methodology. trying, to translate them into their colloquial vocabulary. Because, as you can see, the sessions that we have with them is not that like they are a very small and short sessions. So we need to translate and to give them a lot of knowledge. So sometimes our role is trying to help them, to understand and to see processes with another point of view, not being very focused on the vocabulary, on the tools, but trying to give them a new perspective or of their day activities, so they can, continue applying the methodology.
Okay, thank you very much. It's very hard to put in 30 minutes such a big transformation. We want to put the main characters, even Raquel and Anna, because they are the real protagonists. Even with English, it's not always easy to manage, but they are the main characters. So thank you very much, team. Such a big transformation, still ongoing some of the phases. So congratulations, and a very big example of how a big company organization can transform themselves. And thank you also for the support from the management, Ana Ochoa and Mark Sales. So Chris, thank you very much.
Thank you, guys. So I will take over from here. Thank you, all.